Thilo, welcome to Scotland. I wonder if you could introduce yourself, talk a little about what you do in Switzerland, and a little bit why you've come to Scotland.
Okay, my name is Thilo Beck. I'm head physician, head psychiatrist of Arud in Zurich in Switzerland. Arud is a non-profit, non-government organization that was founded 91, just before the closure of the Needle Park in Switzerland. That was the time of the huge heroin epidemic in Switzerland. And Arud was the first organization and pressure group that really tried to improve the treatment for people with opioid addiction, and also tried to improve the political frame that makes treatment possible. And this was our origin, and I'm still on that track, actually. And I'm here in Scotland for this conference about introducing heroin-assisted treatment and consumption rooms in Glasgow, which I think would be a very important step forward.
And this, you've been to Scotland before, and we've welcomed you and your experiences. I wonder if you could talk a little about the regime in Switzerland and in Arud, and the way that replacement therapy's done. I think one of the issues or the novelties of people hearing about what you do there, from a Scottish perspective, is that it's so alien to what we do, and it's based on a belief system that's completely different from the implied belief system of our treatment services, and perhaps what users believe about themselves, that it's a real challenge to our practice. I wonder if you could describe it.
Yeah, I think there's quite a paradigm shift going on in addiction treatment at the moment. Addiction treatment is getting much more individualized, and it's about the single individual patient, the person that has different. Every person has different problems and different set of problems, and it's always complex. And as we say, with every patient or person we get into treatment, we write a new script. And so it's a collaborative process to find out together with the person you get into treatment what works best for this person. And I think that's new in addiction treatment. Yeah. Historically, addiction treatment has been one size fits all, or the thinking patients have to adapt to treatment systems, and if they are not willing to adapt, they have to leave the treatment. Yeah. And I think we quite reverse this, and our thinking is we have to adapt the treatment to the patient.
Yeah. And so in your collaboration with those individuals, with those patients, how does something like, as would happen here, titration onto ORT and getting at the correct dose and how that dose is dispensed, how is that all done collaboratively with a patient?
How can I know what the best dose would be for one or the other patient? The patient has to tell me, because I don't know how it works with him. I can only advise as a therapist or as a doctor, and we then discuss this. But in the end, it's the patient who tries to titrate the dose to the best for him. And this works. We have been doing this now for 25 years, and there has never been any negative effects, or it has been working perfectly all those years.
And the other thing that's alien here, we have methadone and we have buprenorphine, and there's talk of having heroin-assisted treatment. But the way people move between those treatments or how they are put on those treatments, how does that work with your patients? They choose.
That's something we do that way in the heroin-assisted treatment, where we have like individuals who are quite dynamic about how they use opioids, and they change the dose of like injected or orally taken heroin from sometimes from week to week, and so we try to adapt to that and give the patients the choice to find and redefine the dose of the various substances, and since about 50 to 60% of our HAT patients do combine the acetylmorphine, heroin, with long-acting substance like methadone or like slow-release oral morphine. So this comes into this equation as well, and so we count with opiate units and have these conversion tables where patients get to know themselves, and that's the way they can shift between the substances they use.
Okay. So between you have a prescription, as it were, you have a diagnosis that somebody requires 20 units, but then how that's dispensed on any day or whatever is up to the patient themselves.
I think that's a difference from the substitution treatments with long-acting substances and with diacetylmorphine. Diacetylmorphine is a short-acting substance, and that's much more dynamic the way you use it. So it's not to be compared.
No. Okay. Because we've largely a methadone program, and people tend to be on the lower end of doses, although that is a generalisation. So the two criticisms of ORT in a Scottish context are that it doesn't work, whatever that means, but the patients will tell you that as well as the public or politicians, and that it's expensive, or it's comparatively expensive. Have you any thought on that, or any observation as somebody outside Scotland?
Well, if I hear somebody saying ORT doesn't work, my first question is the substance right and is the dosage right? So I think there is many treatments going on that are not optimized.
Yeah.
And I think if you got the right mix together, that's substance-wise, dosage-wise, but also about treatment of comorbid disorders, then those treatments are very much effective.
Okay. And the question, the budget of the money that's spent on it, or whether that's a good spend or a waste of money, or whatever term we've used. Of course, if it is suboptimal, if they're not doing what they should be doing, and the substance isn't doing what it could be doing, it then is de facto a waste of money.
If the treatment isn't optimized, then it might be a waste of money, or it might be more costly than no treatment, because you have a treatment without effect and a patient that is still not functioning and not feeling well.
And in terms of, when you talked earlier about Needham Park, there isn't a public injecting scene in Glasgow that's quite like the photographs you show in your presentation. But could you describe some of that, what that was like, people's memory of that, including users' memory of that, the public's memory of that, what that all looks like now, what public injecting or that scene looks like now, and the consequences of that for your service?
Yeah, as I said, we are victims of our success right now because the people we have in treatment or are using our services, and this is not only our services, this is the 4-pillar policy in Switzerland. We have all sorts of treatments, like comprehensive range of treatments and help that those people can use, and this was so effective that they are no more nuisance in the public, and I think people forgot, the public forgot about them, and isn't ready to pay for it anymore. I think we have more and more questions coming up why the funding should be continued for the services we run.
Because there is no public use.
Because there is no visible problem.
Yeah. So there's a reluctance to invest in a service that's almost invisible.
Yeah.
Okay. And that takes us on to other aspects that you've discussed around diversion of supply. So you have much more take home than we have, and take home for longer periods, and it's more common. And what's the driving force for that? You know, why can you do that and not worry about methadone or medication being diverted into illicit use?
I think that's what I like about the Swiss 4-pillar system. We try to define what's the duty of what profession, and I'm a therapist, I'm a doctor, and I'm not a police officer, and so it's not my duty to control if one of my patients does divert substances or not. My job is to check on the effectiveness of the treatment, and if the patient fares well in treatment and I see a positive effect, that's the thing I'm concerned about. And if there should be diversion going on, then I think that's an issue the police will be therefore outside of the premises.
Yeah. But as a system, that's true for you as a therapist or a clinician, but as a system in Switzerland you have less diversion than we would expect here.
Absolutely. It's not much of a problem, and I think this has quite a few reasons. I don't know how the situation is here, but it's no problem whatsoever ever to get heroin in Zurich. Whoever wants to get it, that gets it, and not so expensive. So it's available. So it's not so attractive to sell substitution medication. And everybody who wants to get into a substitution treatment can get it easily. So it hasn't got that priority. There is not such a black market as you might know it here. Yeah.
Because there's a legitimate means of getting your medication anyway.
Yeah.
And the other factor in that, of course, is that we're quite proud in Scotland now that people don't have to wait more than 3 weeks to get into treatment, because there's a government target kind of driven that for each local health board area. So, I mean, what are your waiting times, and how do you manage that?
That's, as you say, that's a management job. I think, and that's a question how you set the priorities in your facility, and we are there for the people we offer the treatment for, and we are trying to do our best to meet their needs, and we know that we have to to use the windows of opportunity, and if somebody is ready to get into treatment or thinks now it's the time to get into treatment, we have to really be there, and I think that's one of our first priority duties, and I take this very serious, and it works, and it's just that's a management thing, and I think it's also about convincing our employees that this is important, and we all share this attitude, and so it comes natural.
Because what's happened here is there is a view that when somebody first engaged, their motivation should be assessed. And part of that engagement around their motivation is making people wait for a certain period of time and maybe to do other things to improve their motivation, or for them to contemplate about.
To put it frankly, that would mean the patient has to prove that he is already on the way of that he's already better, and then he can get into treatment. I think lack of motivation or ambivalence is a symptom of addiction, and we cannot expect our patients to wait to get less symptoms before they get into treatment. So I think we have to take those symptoms and work with them.
So when someone presents at your service, you have an interview. What is the process, and how long would it be before they were in treatment or on substitution?
Like regular substitution, not HAT, that's very quick. That's just 20 minutes.
So the home treatment regime is quite different than we have designed here or has evolved here. My other question is treatment generally, and particularly heroin-assisted treatment, politically controversial? Are there politicians who have something to say on that? Is it just regarded as a medical matter, same as a treatment for carcinoma? Or
we have this discussion coming up now again with economic problems and less money around, and so politicians start to question our treatments again, and not being or thinking that they might dispense the money otherwise, rather, and we are confronted with those questions again now, and then we try to show or prove the effects of our treatments, but it's not that easy, since there is no, as we said, no visible problem anymore, and I think that's a tough job.
You're a victim of your own success, Thilo. Thank you very much. Thank you. Thanks.